Health centers, and because our focus was also largely on primary health centers, so this is a monitoring conceptual framework for PHCs that the WHO and UNICEF have developed recently. So earlier they used to have 6 building blocks. The WHO had developed a framework in 2007 in which they had 6 building blocks of health systems. So one was financing, governance, manpower, medical and health technologies, health information systems, and health physical infrastructure. So this was the case earlier. Now they have refined this, the WHO and UNICEF have together. So here if you see, the 3 components are that integrated health services. How do we develop a package of integrated health services? Then multi-sectoral policy and action, because as we discussed yesterday, a lot of things require multi-sectoral coordination. There are 2 terms that are being used. One is health in all policy, which, like as I mentioned yesterday, that I was there in the World Health Summit in Canada. The Canadian Health Minister said every policy is a health policy, because you have to see the impact of health from different areas, because health is impacted by different things. So this is what it means, that primary health centers are the most capable of coordinating with other sectors at the grassroots level, with water and sanitation, with schools, so you have health awareness programs in schools, with other systems. So these are 3 pillars of primary health systems. So integrated health services, multi-sectoral policy and action, empowered people and communities to enhance accountability. So like somebody also mentioned yesterday that they have this, a community engagement to build PHCs, they involve them. So this is at the heart of the health systems, that, the communities are empowered so that they are also involved in the design as well as monitoring and evaluation of these things. Now there are like 3 broad things here. Health system determinants. Now it's not, I'm sure, sorry, it's not very clear, but we also, I don't know how to, somebody is not here. Hey, Amartya, somebody there to make it better? Is coming? Okay. So I can just talk about this. This is, the first thing is structures. Under structures they have 3 things, governance, political commitment and leadership. Now, for UHC, like we said yesterday, the most important thing is financing. But before financing, political commitment and leadership is actually very important, because if there is no political commitment, there will be no financing also. So that is very critical, that how do you, I remember I was doing my doctoral field research in Saharanpur district of Uttar Pradesh, and I asked the local MLA that, why don't you build a primary health center here? He said, nobody asks for it. So if there is public demand, so then the politicians also will do things. So that, and for that we need community engagement and empowerment also. So how do we empower communities so that there is a demand? Like in Sri Lanka, if a doctor does not show up at a primary health center, people go and, surround his house. Why are you not coming? So, there is very high level of accountability in Sri Lanka. And the way they retain their health workforce, so the doctors from Sri Lanka don't migrate to the US and India, UK like in India, because they allow them private practice after 4 p.m. So you work at the government health facility from the morning till 4 p.m. After that, you are free to do private practice. But the accountability in the public system is very high. So, that helps in managing all those sort of things. So, political commitment and leadership under governance is the most important thing. And for that, we need community engagement. Then there is governance and policy frameworks. So, what sort of policy framework is there? How are things governed? For example, in India, health is a state subject. Now, although health is a state subject, the central government makes the national health policy and expects the states to develop their own health policies in the light of that national health policy. Center also gives a lot of money. If you look at the ratio of financing of various programs like NHM, I think there's somebody from NHM also, right? So under NHM, I think for hill states, it was the center's state sharing is 90-10. So 90% is put by the center, 10% is by the states. And I think for other areas, it's 75-25. And if you look at the overall health expenditure, the government health expenditure. So government health expenditure is divided into two parts. One is the central expenditure, the other is the state expenditure. Now, this has been changing over the past few decades because there is revenue sharing in the form of GST and other things. So there a lot of money comes to the states. So the center is saying, you pay for health because health is a state subject. I'm not going to pay so much. I will only give money for. So from the center, there are three types of programs. There is the central sector schemes. There is a centrally sponsored scheme. I think NHM falls under centrally sponsored scheme. So central sector schemes, the 100% money comes from the center. Centrally sponsored schemes, there is revenue sharing. So 75% I'll put, 25% you put from your side. So this sort of governance framework is also very critical. How do you develop a governance framework for health? So that has a lot of implications. Because when something happens, they will put it on the state. If there are child deaths, for example, in Gorakhpur, children died because of lack of oxygen before COVID. Now they said health is a state subject. If something else happens, the center wants to keep the levers. Like for example, pharmaceuticals. Medicine approval is by the CDSCO, the Central Drug something Standards Organization, whatever. Or also for food, FSSAI is the central body which is part of the Ministry of Health and Family Welfare. Now they have state offices. CDSCO also has state offices, but at the state level, you cannot approve drugs. Like the Meghalaya government cannot approve drugs. They can only give a license to manufacture here. So licensing is allowed to the states, but approval of drugs, new drugs, is by the center. So, there are complexities like this, and there are things that need to, so all this comes under governance and policy frameworks. Then engagement with communities and other multi-sectoral stakeholders. Now, this also comes under governance. So what is the modus of engagement with communities and other, sectors like water and sanitation, public health and whatever. Again, engagement with the private sector providers. So do you have a public-private partnership? How do you engage them? How is the money paid? Like under CGHS, the Central Government Health Scheme, there is empanelment. Also, I think under Ayushman Bharat, there is empanelment of private providers. So how much do you pay them? How does it all work out? So that is all covered under governance. Then you have adjustment to population health needs. This is also what we discussed yesterday. Whether there is monitoring and evaluation or not. I mean, this is quite restricted actually. I would personally expand this because there has to be a more systematic method of continuously assessing the health needs of the population. Because you have to see, so this will be a mix of many things. One would be the, a clinical method that you get data on morbidity from existing health systems. Like somebody was saying, there's a health survey on NCD risk factors. So you are monitoring the population on NCD risks. That is generating a lot of data from the community, or if it is opportunistic screening, that people are coming to health facilities, you are screening them. So that data needs to be collected systematically and analyzed. The other is that, you also get data from the private sector, because private sector does not share data. Now again, like we were talking yesterday about antimicrobial resistance, the private sector says we will not share data with the government because first of all, we need to put people to, to develop this data, to data entry, because it has to be done. Then if you share data with the government, then there are implications of, because for example, if somebody dies or somebody develops resistance to antimicrobials, now the government will blame the hospital. So there is, a lot of things are there. And so those sort of challenges have to be addressed. And we have to see how do we get this sort of data streamlined from different sources. And then, so this would be the systemic side of things. The other would be, how do we talk to the people? So how do we engage with communities to understand their health needs? So talking to them, what are your health needs? Because this data may not necessarily be accurate. I'll give you an example. Let's say there is a person who has diabetes, cardiovascular disease risk, who has, let's say, high blood pressure, he or she has multiple things. Now, this person is traveling on a flight and there is a plane crash, for example. Now, the cause of death will be written as, plane crash, accident. So, WHO's classification is, one is communicable maternal and, neonatal and nutritional diseases. B is non-communicable disease. C is injuries. So, injuries include self-harm and also, accidents and all of that. Now, the cause of death here written will be plane crash. Now, this cause of death data does not give you enough knowledge about the person's disease, because this person also had diabetes, high blood pressure, cardiovascular risk disease and multiple other things. So, so right now what we are doing is, we are almost exclusively relying on cause of death statistics, which is already very weak in India. So, if you see, birth registration is very low in India. Let me also tell you here again that there is this Registrar General's office which collects data on deaths and births. Now, that data, and again this is a problem with the HMIS also, that there is no denominator. The denominator problem is actually one of the biggest problems in government health data, because you don't know how many population was supposed to be covered. You don't get the percentage. You always say, we have given vaccination to 50 lakh people. Now, I don't know what is 50 lakh, what is the percentage in terms of your total population. So, 50 lakh might be 1%, 50 lakh might be 100%. I don't know the percentage. Then I don't know the people who are missing out. You don't get data on those who are missing out. That becomes a huge problem in government data, and as a result of that, government reports are flawed. They are wrong, because they have this estimation, they have this estimated number of births, estimated number of deaths as the denominator, which shows that we have registered so many births in Meghalaya, let's say in 2020. 58 lakh births happened in Meghalaya in 2020. Now, I will say, have you covered all births in Meghalaya? So, you will say, these are institutional births. We don't know home births that have happened, but our estimate is that so many children might have been born. So, that's an estimation, and your estimation can be wrong. Similarly, for deaths, the denominator is the estimated number of deaths. That is the problem with COVID also, because COVID, a lot of, the cause of death were written wrong, and the government also wanted to hide data. Even Kerala government was hiding data. So, everybody was hiding data on COVID deaths. They did not want to show the weaknesses of health systems. So, that becomes a huge problem, because you are not getting the coverage of birth and death registration. Now, without death registration, if you look at the latest report of the medically certified cause of death, they say that 22% of registered deaths have been assigned a cause of death. Now, first of all, the registration of births and deaths itself is very low. On top of that, the medical certification is very low. Now, the story does not end here. Further, if you see, like we were talking to the esteemed doctors here, they were saying a lot of doctors are not trained on how to assign a cause of death. Now, even there, if you see, there is a category in the Indian system that some, miscellaneous, some category. So, 10% of the deaths are under the miscellaneous category. Now, so the reason why I am saying all these technical things is that the data to assess the health needs in India is very poor. So, ultimately, we will have to go to the communities to discuss with them, and that will require multidisciplinary groups who go there. So, it's a mix of doctors, qualitative researchers, who talk to these people and try to understand the community health needs, because existing data sources are very, very weak, which is why we have estimations. Again, I'm saying, because of the poor quality of data, we have estimations from the global burden of disease, and we say that, okay, so many people are dying due to chronic disease, this and that. So, this is a very important category. Otherwise, what is happening is that in the absence of this, we are shooting in the dark. Now, how do you define that, what sort of health services are required in the state of Meghalaya. Like if I ask you, so how do you decide? Please, anybody? How do we decide what health services do we provide in Meghalaya? And how do we know the present status? Exactly. No, but how are those programs developed? What is the baseline data? That is not there. So we are just caught up in this, some old-fashioned thinking. So first of all, in the Ministry of Health, there is a perception that population growth is the central problem, which is why we always have Ministry of Health and Family Welfare. So family welfare has been at the foremost of everything. Now we don't realize that countries in East Asia, they have very low fertility. When women's education improved, development happened, already automatically the population growth declines. So that they don't focus on. The focus is giving contraceptives, this and that, and then they feel that so a lot of focus is on reproductive and child health to control population growth. Because the logic here is, if we control population growth, everything else will be fine. That sort of intrinsic logic is there, which is why under NHM, I think almost 70% of the funds go to, even in Kerala, which has 90% of the deaths happen due to chronic diseases in Kerala, but 70% of the funds are going into reproductive and child health. So the thing is, we don't have this sort of system of analyzing the health needs. So this area, this side is very important. Then financing, I mean, we know that where does the money come from, who pays, and how do we get all that money? So this is the structure side of it. The input is physical infrastructure, health workforce, availability of medicines and other technologies, health information systems, surveillance and all of that. Then this is, I have to see that. This is processes, sorry. This is the process side of things. So models of care. So these are all technical aspects. Then important thing is outputs, access and availability. Like somebody mentioned yesterday that geographical areas, you can't provide. That's a big challenge. Geography is a big challenge. So how do you make things available there? Then here we also have affordability and acceptability. Like somebody was saying, trust issues are there. People don't accept. So you can keep talking to them about, the need for these services, but they will not accept it. So here utilization of services, trust, all of that comes here. Then quality of care, again that we discussed yesterday, that how is the quality of care, and if it is not of high quality, it will not lead to the desired outcomes. Now, then the outcome side, we have universal health coverage. So when you do all these things, when you solve the challenges at this level, these are the things that you achieve. Universal health coverage, and then SDG 3 and other health needs. So in the light of this framework, can we classify the challenges that we identified yesterday and group them together very quickly? So we have the presentations. So we can put the governance side framework, the challenges in one slide. Similarly, we can put financing here, health workforce challenges here, medicines here, health information systems, physical infrastructure, continuum of care. So we can quickly classify what we discussed yesterday, and then based on this presentation, we can develop solutions. Does this sound like a right thing to do? Any other alternative suggestions? Because if we all work on the challenges that we have identified, we don't have this common framework, to develop solutions. So how does this sound? Should we do this? Or should we just focus on the challenges that we had identified yesterday and we develop solutions to them? What do you think would be a better way to do it? Yeah, please. How do we develop the solutions according to that? No, so the question here is, do we focus on the challenges that each group had identified yesterday, or should we develop a common framework of challenges, taking everybody's, putting them together in one common framework. So what do you suggest should we do? I'm open to both ideas. I mean, I'm fine with both. Whatever is fine with you all.
Best combined because yesterday also as you can see that some of the
They were all
challenges are different.
Yeah, exactly.
Each group challenges.
Yeah. So we can combine the challenges and then we can have different groups working on different challenges, right? Is that what you're saying? Combined approach to the challenges. Great. So if we take out the charts are here. So can we start? Oh, no, actually, light is gone. Okay. Then but the thing I was thinking, we can type it here and everybody can see. So, yeah, so maybe, when will the light come? No, we don't know. Okay. Okay, it's here. So maybe we can start with 1 point each and then quickly classify them under one category, different categories, and then we have a common presentation. Is that fine? So may I request you to please just let me know and I'll keep classifying it under different. I think the way this helps all of us is that we also come to a common understanding of challenges, and then we work together on solutions. So the first one here was on geography. Geographical disparities. So one is the geographical access side, and then I think somebody mentioned yesterday that the resources are also inequitably distributed across geographies, right? That was also one of the concerns. So one would be the geographical accessibility, we can call it, access issues. Geographical accessibility, so this would be remote areas, right? The other would be the inequitable geographical distribution. Distribution of resources. Okay. And what was the second point here in this? First is about the geography, right? The second? Yeah, maybe you can take one chart in. So anyone can give me any challenge from the sheets and I can just classify it. Anyone can give me any challenge. No, any. Because I have to. Okay, financial reforms. So what should I write here? Okay. So financial awareness for health system workers. Okay. Financial awareness for health system staff, right? Staff, health system staff. Is this fine? Is this fine? Financial awareness for health system staff? Okay. Now, what about the adequate financing? That's a great point. That's a great point. What did you say? So adequate planning with strategic. Okay. With strategic planning. So, for allocation and purchasing. That's a great point. So what else? What is the next point then? You can also tell me any point. Because I am classifying different points. Anybody can mention any point. You can also join with them because we want to collectively build up one sort of challenge framework. Who has a third one? Third sheet is with strengthening of primary health systems, right? So governance, right? Strengthening of primary health systems. So strengthening would be across the whole thing because so network, well equipped. So this would cross-cutting theme I can mention here, right? This would be a cross-cutting concern because this will be also about infrastructure, staff, yeah, exactly, financing and medicine availability also is there or not. So any other point? Okay. So health workforce, right? Limited integrated approach towards human development. You mean health workforce development? Ensuring adequately trained, adequate and well trained health workforce. Okay. So integrated, when you say integrated, what do you mean by integrated? Multi-sectoral. Okay. So this will go under governance, I think, na? Integrated one. Governance. So limited, integrated and multi-sectoral coordination we can say, right? Limited. So have I put this right? Please tell me. In limited multi-sectoral coordination. Is this what you meant? So should we say no multi-sectoral coordination? No, this came from here. It's not mine. So what do you suggest? That's a challenge. No. We are writing challenges. So this is the common template for challenges. No. Right now we are developing a right now. Yeah, please.
Develop a roadmap regarding the conditions that are
developing a roadmap. Okay. So where do you think this will go? Governance? governance. So please can you repeat? Lack of roadmap. Challenge. Lack of roadmap for?
regarding the various conditions like people are facing now.
Okay. For various health challenges. So should we say key health challenges? Like for example, like there should be a strategy for diabetes, for how do you tackle diabetes? Determinants of health inequalities. So that would be a study. That would. Acha. So health inequalities would be one component of the whole thing. But the presence of various conditions is there. So first is that we have a lot of health conditions. Then there are inequalities within that. So should we say lack of roadmap for assessment of various health challenges and solutions? Because we don't have a roadmap to. No, so roadmap is for solutions. No. So roadmap is for solutions. Roadmap is not for challenges. So we need to remove the word roadmap. So lack of assessment for various health challenges and roadmap for solutions. Oh, sorry. So various health challenges, health inequalities, as well as roadmap for solutions. So is this right? That we don't have assessment of various health challenges and health inequalities, and there is no roadmap for tackling them. You can say tackling them, these challenges. So other points from the chart that we had, access to technologies. You mean medical health technologies, right? Access to technology in general and medicines also, right? Sorry? And essential medicines. Now, one question here. How do you decide which essential medicines should be there in a PHC? There is an essential drug list. Okay. National list of essential, state list also. As per the state list of essential medicines. So, medicine availability is not there. That is what you say. So, access to technology. This probably you can availability of, what is the other point mentioned? But any point can come, because right now we are categorizing all of these challenges so that we reach a common, consensus around. So maybe you can just read from the chart. You can just read. Or from this chart, any chart, you can read the challenges which are written. Health information systems is a different thing. It's this is health information system. Not fully utilized. Okay. But is it strong enough? Do we have adequate data from the health information system? Lack of declassified. It should be Oh, okay. Okay. So, So how do we write it? Lack of classification? Right, right, right. Okay. So maybe we can also say that lack of adequate recording of data or something like that. Or how do we frame this? Sorry? Okay. Training. So training. But we here we can say lack of this properly classified data. You can say, right? Data and also data analysis and use. Sorry. Data analysis and use was a challenge, right? This was a major challenge. I think many people agreed yesterday, mentioned that data analysis and use is a huge challenge. So, that's a great point. Because so then that would be the data flow, multi-directional data flow or something like that. It has to go from the bottom to the top, then also come back. But one question here, can data analysis also happen at the grassroots level, local level, at the PHC level? Exactly. So, but does that approach help, because you are giving targets to people at the grassroots? Okay, so data flow, bottom to top to bottom. That is missing. Bidirectional. Bidirectional. So here this can come here. Bidirectional data flow. So one question would be, how does this data flow help from top to bottom? How does this help? So that is the situation right now. Any other thing, right. Data sharing. Acha. And also, if you want to involve communities, the data should be shared with communities also. After it's analyzed, yeah. With grassroots workers and communities. Can we say this? Lack of data after analysis. Not raw data, after analysis. At the PHCs. VH, village health. Village health councils. Lack of data sharing with health facilities. Should we say health facilities? Right. So the data is not being shared back with them. Okay. Great. And here should we also mention skills of the health information system staff, because if they are not adequately trained, so is that also an issue? Should we mention that also? Okay, other challenges from the sheets yesterday. आपके पास भी एक sheet है? Yeah. From different points. Okay. Sorry? Should start talking to one another. That's also a great point. Centralized data repository and access. And universal access, should we say? So that everybody has access. So you were saying, so your point would be that this should be integrated data, centralized data repository.
For example, let's say diagnostics. Tests for one patient. One patient. So this one patient will do this number of tests. Right? This one patient will be a better number. Now it will be another app, it will be this patient has come from this.
Not talking.
Another test will be performed.
Very true. Data systems should talk to each other, not talking to each other. This will be a challenge. So this leads to data fragmentation. Controversial. They don't want to share with everybody?
There's also the point of accountability.
Exactly. Yeah, because you know. That's exactly. So should I say cleaned up? Cleaned up. Okay. So this also is linked to accountability at the community level, at every level, at various levels. So other points, yeah. What are the other points? See, the idea of this is to collaboratively develop a common framework for challenges, because I think yesterday it was all group wise. So we also need to converge to a common understanding of it and shared understanding. So other points, so let me go through this one by one. So governance, any other thing that is there in the sheets from yesterday? What governance? Cost. So that should probably go into financing, right? Cost effectiveness analysis. Analysis of interventions. That is. So does any agency do that? Cost effectiveness analysis? No, there is nothing like that, right? There is nothing like that, no? It's not done. NHIS, what is NHIS? MHIS. Okay. Acha. So we should probably mention this, that MHIS has done sorry, MHIS has done a survey on this. They have done it. So is this a survey or a study? Study by Equivia. Okay. So Equivia did a study for MHIS on cost effectiveness, but it's not up to the mark. Okay. Up to the mark. So that would go under governance, collaborative partnerships with NGOs. Acha. NGOs, IOs, international organizations, public sector. Oh, sorry, private sector. I meant. Mhm. And is there a survey of health workforce in the states? Like, do we know how many doctors are there in the state? Is this a census or a survey? Census. It's ongoing. Who is doing that? The health system strengthening project. MHSP is doing that. So we should mention in the health workforce. What is it called? MHSS. The survey, the census, the agency. MHSSP. Census of health workforce is happening. Okay. And what is it called? The census is called? HRH. HRH would be Manav, like this, right? Sampada. Okay. Manav Sampada. We can do a Google search. See if this is correct or not. Manav Sampada, Meghalaya. Yeah, it is right. EHRMS, Manav Sampada. 100 points. Okay, we can also give the link. EHRMS. EHRMS, Manav Sampada. Yeah. So, what else? So, this Manav Sampada will have a census of all the health staff. And this will be updated on a regular basis or not?
Based on this,
will be developed. Okay. Based on this, HRH policy will be developed. Is being already being developed? Achha. Okay. Is being developed. But this is complete or not? So then how is the policy being developed? Simultaneously. Okay. So what else? What are the other challenges? Because let's complete this and then have a tea break, and then after the tea break we can work on solutions, because then we'll have a common template. So then we can start. Anything left from here? Maybe we can just have a look and see if anything is missing from here. So preventive care at primary. This is your thing, right? So maybe you can tell me what else is missing, starting from.
these are the challenges.
Okay. So, but this is what?
Status.
This is the status. Oh, great, wonderful. So, please, can you mention one by one, so that nothing is you can just read out. So, this is covered. Yeah. Sorry, just a minute. Lack of adequate, well-trained and skilled. Okay, done. Manpower issues mean, but that's also health workforce. That's covered. Okay, just 1 minute. Inadequate equipment. Infrastructure would be a separate thing. So by infrastructure you mean the physical infrastructure. Inadequate. So you mean lack of PHCs and all of that. District hospitals also. Huh? Okay, what else? Oh, stigma. Huh? That's okay. Mental health. That's a great point. So we'll have to create a different slide for it. Or should we say put this under access and accessibility? Because if there is stigma, they will not. Stigma, social stigma around and discrimination also. There is discrimination also. Oh, on mental health issues. Oh, so what do you mean by awareness is also not there? Acha, so awareness is also not there, na? That's also limited awareness, social stigma and discrimination around mental health issues. Is this fine? It's fine. Okay. So what? For mental health. Is this mental health? General. Lack. So when you say lack, so like do you have a target that okay, this is the target and this is not being met? So how do you decide whether this is limited? General. Okay. So adequate financing is already there. It's already there. So should I also mention here with adequate financing compared to population financial situation, right? Is this fine? Inadequate. Right. Inadequate financing compared to population's financial situation. Inadequate. So that can be a separate point, I think, because this is. So when you say inadequate strategic planning, do you mean covering promotive, preventive, curative, all of that, put together? Vis-a-vis, we can say vis-a-vis continuum of care. Right? Is that fine? Promotive, preventive, etc. Curative. What else? Okay. Of proper documentation. So that would come under governance. Where would that go? Governance. Again, governance. Governance. So, limited multi-sectoral coordination, you can say. But also we can mention here this lack of identification documents or something. Lack of identification documents. So can you explain this? Do you mean that if somebody does not have an Aadhaar card, will not be able to get access to health? To HMIS? MHIs. Okay. Without this, and there is also hesitancy to get this identification, right? That is also there. So that would go under hesitation also is there, right? So that also needs to be mentioned here, that public hesitancy to get such documents. What else?
There is also a way to be and do all this stuff.
Right. It takes. So if somebody does not have this Aadhaar card, will not get MHIS coverage at all. Okay.
The SDG has been back.
Sorry? Okay. They have this sort of map. Mandatory. Okay, the MHA. Okay. Abandoned cases. Oh. Oh, so abandoned cases due to no possessions. Oh, no family, no documents. Okay. So is this a big problem here? Well, oh God. So what happens to them then? Oh, shelter. Oh, shifted to shelter homes. These are very critical challenges. I mean, What else is there?
So we have dispensing leave system.
Okay. So where would this go in this category? This would be outside of health systems. Community engagement, would this go? Belief systems, beliefs and cultural practices. They will not accept. What else is there? Yeah, that we have mentioned. Yeah, that is mentioned. Yeah. What else? Power supply would come under physical infrastructure. That's also a very important point. So disrupted power supply, lack of uninterrupted. Oh. To address this. Okay. What about healthcare waste management?
Yes, that is also important. This is surveillance going on now.
This is going on.
This is surveillance going on now and addressing the level.
And drug disposal, especially for injection safety, because if you just, how do you, they are, it's happening. Steps are being taken. Drug disposal, you mean expired drugs? Okay. Because with this, is there One Health surveillance? Because you see, if you throw these expired drugs in the environment.
Identifying agencies, of those agencies,
Expired drug. So, in health information systems, do we have One Health surveillance?
it's under the MHSSP level.
It is there. MHSSP is doing One Health surveillance.
They're doing that, biomedical release management and
Equipments management. No, but this One Health would be about antimicrobial.
This is other one, right?
For One Health. Last month it has started. So, under which? Under NCCH. Oh, okay, okay. So, this. What can you name the program? Which program? Okay, which is being managed by this NCDC, National Center for Disease Control. The NCDC managed. National Program for what is the short form? National Program. NPCC HH and create One Health surveillance is going on. Okay. Sorry? Heat related illnesses. Air pollution. Okay. But Meghalaya does not have this heat problem. There is no fan, there is no heat. So there is the. Achha, border areas. So heat related and which one? Air pollution. Air quality. At the moment. Okay. But what about the other things? Cyclones and earthquakes and flooding. No, disaster, but the impact on human health. So this is all part of climate change, right? Eventually it will cover. What about emergency preparedness? Like COVID. COVID happened. What is being done for emergency preparedness? But is there a plan for tackling health emergencies? Okay. But do health systems have the... So is IDSP integrated well into the system? Because then you get warnings, early warning systems. So EWS is functional. Okay. Okay. Wastewater surveillance also is happening. So wastewater surveillance is happening, and IDSP, EWS is happening, and this is fine. Ongoing. It's quite robust. So, I mean the performance. So the performance here would be measured by the number of outbreaks, epidemics, and emergencies. So, what is the level of outbreaks? So, like foodborne illnesses and other sort of illnesses. So, how many outbreaks are happening here? IDSP. Oh, okay. Okay. 3 outbreaks in entire Meghalaya, and they were about from which foodborne illnesses. What sort of outbreaks? Foodborne illnesses. Okay. What about epidemics? There are no epidemics? Okay. So you are saying that wastewater surveillance and IDSP early warning systems is fine, is ongoing. No, but so I'm trying to say if this is a challenge or not. It is. Okay. So these things are taking up a lot of resources. Resources. Okay. But this is the public health, not the health system per se. This is public. No, but by health system I mean the primary health systems. But primary health. No, but to be prepared. Ha. Ha. So, but this IDSP data is collected by the primary health systems, sub-center to upwards. PHC. And then it goes up to the national level. So, the public health department, is there a public health department here? There is no public health department? There is no public health department as such. So what about municipalities? The municipalities would be doing a lot of work, like cleaning and sanitation and what about the decentralized the elected bodies? So municipalities at the urban level. In rural areas there is this panchayats. So are they responsible for monitoring all this public health work? No. Anybody knows about the public health side of things? Like sanitation, water, and all of that. Acha. We don't have any public health person here. There is village by PHE. Oh, okay. That's a great point. So we can write under governance, village health sanitation committee. VH health sanitation committee is there. Committees are there, and they are being managed. Acha, nutrition. So, village health, sanitation and nutrition. Acha, हाँ. Village health and sanitation committee. Acha, so this is there. Village, sorry. Village Health and Sanitation Committee managed by the public and nutrition also. Sanitation and nutrition. Okay. So village health, sanitation and nutrition committee. So VHS NC, right? Correct? Is this correct? Is there and managed by Public Health Department. Public Health Engineering. So should we write this as a challenge or? Acha, so staff is not. Okay, so there is understaffed. Should we say this is understaffed? Communities are not involved. Sorry? So how should we frame this? What should we say? Resistance to participation. Sorry, resistance to participation in lack of health seeking. Resistance to behavioral change. No, but I don't. So this committee is comprised of local population, and there is a resistance to health-seeking behavior in this committee. Okay. So the communities are resisting their programs on behavioral change. Okay. Communities are resistant to behavioral change programs of So is this correct? Communities are resistant to Is this fine? So any other point is missing right now? Public. So you mean this will be in the physical infrastructure? Lack of day centers, you said, right? Lack of daycare centers and special schools for children faced with physical and mental health issues. Okay. Acha. Okay. Physically and mentally challenged. But they use term different. Differently abled. Physically and mentally. Or we can just say challenges, dealing with physical and mental health challenges. Any other issue that is missing? So if this is done, we can break for tea. Any other point which is missing? Any other thing? Otherwise, we can go out for tea and then come back again for solutions. Should we close the session now? Should we close the session? And we can go for tea and come back and work on solutions part. Okay, great. Thank you so much. So we come back and then work on solutions for two. So in solutions, do you think different teams should work on different areas, or should we combined? Combined. So no groups, but everybody works together. Okay, great. Wonderful. So we meet in 15 minutes? 15 minutes? Okay, great. So you suggested that everybody works together on the challenges and develop solutions together, or should we form groups? Groups? Together? Already club, yeah. So should we go one by one? How should we do? What do you suggest? One by one, So do you want me to anchor the discussion, or do you want to do it among yourselves? Anchor, okay. So I will keep typing then, right? So let's we can start here itself, and then for solutions we can just write the solution here itself. Okay, so the first challenge is strengthening of primary health system network. This is a broad challenge, but I think there is a World Bank program going on health system strengthening, right? MHSSP, but it does not focus on primary health systems. It does. Okay, so then what should we say that? What should be the solution here? MHSSP. Is going on, but it is focused. Acha. So, any solution that we want to give here regarding this? The whole state. But they will say, okay, this is a pilot, we will do it eventually after that. So, what should we, this, as we said, is a broad theme, but what do we write here? Like, are there efforts being made? So, the efforts right now is the MHSS, sorry, HRH. Yeah, we'll get on to the specifics in the other thing, but broadly, what would you suggest? What should be the solutions here? So, when you say strengthening of primary health system network, what is the biggest? Okay. Invest in the most important resource, the human resource, the HRH. In recruitment, retention, training and retention. Recruitment, training and retention. Is this fine, everybody? What about education, medical education? Training, it will come. Okay. Any other solution here at the broad level? Broad, because we are talking about the primary health system network. So, one is that are the primary health systems focusing on promotive and preventive care? They are. That's the number one priority. Okay. I think in solutions, we should also talk about good practices in Meghalaya that can be shared with other states also. So, good practices, GP, we can say GP, would be that primary health care is also focusing on health promotion and disease prevention. Strongly or strongly on health promotion and disease prevention. Great. Any other comment here? So, GP is good practice that can be shared with others also. Is it, now from a universal health perspective, is it covering all populations, but geographical issues are there? Accessibility is in. Limited resources is there. Now we are discussing solutions. So, what should be the solution? So, what about leveraging IT? So, what is that? MMDSL Corporation for medicines.
So earlier, I mentioned all these drugs and medicines. This is my process.
Okay. So now this is
This MMPS, we just started. MMPS, we one stop, it is a mine, it will MMPS.
okay. So the procurement is through them or manufacturing through them? Procurement. Centralized procurement. Okay. So is this for all programs or certain programs only? Oh. So should we call it a good practice? Very good. VGP. Very good practice. Okay. Okay. So this is one. Duplication. Reduced duplication. Okay. So. Software is being used, producing data. Does it also produce data on consumption of medicines and can you then through that also do assessment of disease burden? That can also help, but assuming that the prescription is correct. Okay. EDL. Okay. As per EDL. So what else should we write here? Now population coverage is it sufficient through the primary health systems? But what about the geographical challenges? How should they cover? So one is that.
This is one solution. It is MMPS.
Now
the centers, the primary health centers, the delivery of the drugs will be at the center.
Through the MMDCL. A delivery at the centers. Okay. Okay. Great. Now, how do we solve the problem of PHCs in the geographically, isolated area? Who can be linked? Program officers can be linked with. But so accessibility in remote areas, what do we do about that? Telemedicine is already going on. Drone, acha. As a GP, you can say telemedicine and drone delivery of already happening. But what are the challenges in telemedicine? You can't do diagnostics, right?
You can do radio diagnostics.
Radio diagnostics can be done. But what about sampling, blood sample? You don't. And so how do you solve the diagnostics problem? Labs in these areas. But drones can also be used for taking samples. They're doing. Oh, so drone delivery of drugs and samples. Diagnostic samples, right? So I think we already have a lot of solutions here. But is it cost effective using drones? That we don't know. Okay. Because drone might be, expensive thing, so. Don't know the cost effectiveness of using drones. Okay. They have a hub for drones. हाँ, अच्छा. हाँ, where they all come. And then they are okay. Okay. So, what do you mean by hub and spoke model for telemedicine? Okay. Mhm. Oh. Calendar of availability of doctors. Uh-huh. And there are targets also. But targets, so if there are no patients, so how do you? So they only have. Okay. Okay. Uh-huh. हाँ. Hmm. Mhm. Okay. Documentation is there. So, but what about the referral system? When you say hub and spoke model, is the physical? No, but between primary health system and tertiary facilities and backwards also, because in chronic diseases, two-way referral is happening. Okay. Oh, but is it like? Huh. So we can say two-way referral system needs to be strengthened. System needs to be strengthened um, for appropriate management of chronic diseases in particular. For anything, right? Okay, so let's remove that. So this needs to be, but how should they do it? Everything. But can IT help here? Exactly. Right. To come there. What about medical records, electronic medical records, the EMR? Digitalize health records. So that this part is done. So any other further thing under strengthening of primary health system network? Then we can move on to the next issue, which is limited multi-sectoral coordination. Now, how do we deal with multi-sectoral coordination? What are the solutions? Now, health should be your only policy. Communication. So no, but what is the solution? So let's say you are the chief minister and you say, okay, tell me, how do I solve this problem? Committee, digital platform. That's a great suggestion. Yeah, because I think in the I'll give you an example here. So I did a study funded by the British government on health. Food sector regulation between India and comparative study of food sector regulation in India and the UK. So we went to the Food Standards Agency in the UK and we talked to them. How do you coordinate with other departments? Because UK also imports a lot of food from other countries. Now there was this surveillance team, very, very highly equipped with the latest technologies. Their budget was £2 billion a year, just for surveillance, foodborne illnesses, this and that. A lot of food comes from other countries. They say, even before the food lands on our ports, we know where the challenges are. Let's say it's coming from Tanzania, and we know that there is some agricultural problem going on in Tanzania, or they are using pesticides, or there is some disease going on there. So we collaborate with local organizations there and try to solve the problem there itself, even before it reaches us. So they use a lot of surveillance actually to identify those problems. Now, then we said, how do you collaborate with the agriculture department, this and that. So this is, they also mentioned that we raise the problems on a common platform and then mark it to the concerned department. And they have to respond to that. That, we have this problem, what can you do to solve it? And they have to respond to it. And then there is also a regular meeting between various departments. And the head of the Food Standards Agency said, most of my time goes into talking to other departments. He said, I am constantly talking to other departments all the time, almost all the time. I am in meeting with them. I am trying to see how we can work together. So that is something that, then we also went to something called the BEIS, which is they promote the industry and facilitate, ease of doing business for companies which are part of the food system. And then they also said that, they have systems. So, so first of all, this sort of coordination has to come from the top, from the CM's side, for example, that sort of understanding should be there. And then from the top, they can have more meetings, Like, I'll give you an example from the G20, the group of 20, which India is also hosting right now. So, so we used to do some policy briefs for the G20 for the Ministry of Finance, Indian Ministry of. So we were supporting the Indian Ministry of Finance develop its health position in the G20 forum. So we used to make presentations to the G20 Sherpa, because every country is represented in the G20 forum through a Sherpa. And the Sherpa at that time for the G20 was Shaktikant Das, who is the RBI governor. Now he had an interministerial meeting. So I worked on health, so I made a presentation on health. All other departments, ministries were there, and there was also a person from the health ministry. But the problem was, so there are people from different ministries, and let's say I am a health expert, I make a presentation, everybody is listening. But let's say if the health ministry person, the representative, does not agree, the Sherpa is not going to accept anything. So that maybe other departments agree with what you are saying, but unless the line ministry agrees to something, that becomes a problem. So how do we solve those sort of challenges? That there has to be some mutual discussion also in that, or do you think the line ministry should take the final call? If everybody is giving their view. Right. Decentralized. Yeah. Decentralized. Bigger ones go up to the top level. Now, how do you also bring in communities here? Communities, their views. So, the communities also have their views on, how things are affecting them. So, okay, bring it to this forum, and yeah. So we can say there has to be a approach to layered approach to raising challenges and solving problems, and using different platforms, IT as well as personal, like physical meetings, and so we can. Anybody has any other suggestions on this issue? So layered and also consultative, we can say, right? Approach to raising problems and developing solutions. Any other points here somebody would like to mention? So also studies need to be done to show that how, let's say, in this locality everybody is developing a stomach infection. So you need to do a study that, let's say, poor quality of water is leading to that infection. So that sort of, that is there. Right. Achha, it's coming. Can you please elaborate it a little bit?
That's what we used to do, sir.
You can come here. You can come here because I think it's also good for everybody to know how these things work, because it's very helpful. Yeah.
Actually, as of now, we can do it proper way whenever outbreak happens. So other departments, suppose if it's associated with food, so other departments, if you suspect like from the water, the source of infection, so PHES will come to play.
Okay.
Even municipal also. But this is, at this level, it's not that proper, I should say.
Okay.
We're planning to do in the best way.
Okay. So this is so you identify a problem, then you communicate it to the concerned, and then how do you know if they have taken the action, right?
No, that's what.
Oh, okay. Acha. So problem is raised, but you don't know if the problem is solved. Acha. So that is not there. So we should say layering to raising problems and developing solutions, developing and monitoring solutions also. Monitoring and evaluation of solutions, right? Because right now we don't know what has happened. We have just raised the problem. We can also write it here. At the moment, the problem is raised to the concerned department. To the concerned department.
Related departments, concerned related departments.
Concerned?
Related.
Okay. To the related department, but we don't know the status of action, right? And follow up or whatever. Okay. Follow up is never done. Okay. Follow up is never done. Acha. Great. So this has to be more sustained, and monitoring and evaluation mechanisms have to be built in to this whole thing. Continuous and built-in monitoring and evaluation systems, mechanisms. Acha. Then forget everything. Knee-jerk reactions should stop, and there should be more sustained, more sustainable solutions. So, can I also ask about what is happening for COVID? COVID, has disappeared. Disappeared meaning it's become endemic. So it's endemic now. But is there a focus on COVID-19, or people have just forgotten? It's over, it's done. Still testing. There is surveillance. Wastewater surveillance. Individuals. That cases. It's happening on a regular basis. Acha, acha. Okay. So wastewater surveillance of COVID-19 is going on. Is ongoing, but no. Acha, acha. But not enough data to warrant. Acha, acha, acha. Acha, but data is not enough data analysis. Acha, so we are talking about solutions now. So we should say data analysis should also be done. So data. Okay, okay. So what should be the okay. So what should be the solution here? Yeah. Okay, but the solution would be that collect more data from more sites. Lot of data. Analysis is not happening. Okay. I see. COVID. Okay. So we'll say. So should we mention this as a good practice? Huh? So everybody agrees on this. You don't have to agree. You can disagree also. You know. I mean. So this is a collaborative exercise. You know, all of us should participate, and so we are developing joint, solutions. So you can please feel free to disagree, with everybody and anybody. And so yeah, if you have a different thought. So what? Anything else on multi-sectoral coordination? Between health centers. Okay. So you mean different levels of centers? So how should that be done? Transportation? Information sharing. Acha. So we can say information sharing between various health centers. Okay. Is the information shared between laboratories? The diagnostic information is there on a daily between laboratories. Acha, from there it's shared. Great. Any other point? If not, then we can move on to the next point here, which would be so this is done. This would be point 3. Lack of identification documents. This would be 4. Okay, so what do we do about this issue? So awareness is like you are assuming that people don't know, which is why they are not getting these identification documents. But what? So maybe doing a study on why they are not doing this. Sorry? No, but again, what you see as a misconception is from a certain standpoint. So, like you are using the lens of modern medicine and then saying that this is a traditional belief and this is wrong and you should do this. This is from a certain lens. Maybe from their lens, this is wrong. So So what would be the solution here? How do we solve this problem? Mhm. Right now this is happening, but still people are not accepting. Study around behavioral change. Studies should be conducted. Maybe it's around on reasons and behavioral change. Behavioral change strategies, right? How do we get this done? Because I think when you say they're not accepting or change has to be done, you are not going into the roots of the problem. Why are they not doing it? So unless, and also talking to them about solutions, so what do you think, what will make you do this? Let's say a child is not studying. Talk to the child, why are you not studying? And what will make you study? What should we do? So we change their belief? Their understanding. You want to say something?
They change the perception only, but they land in the hospital.
They don't change. Okay. So impact assessment of awareness programs. Ongoing awareness programs, right? Is this right? So is this the right framing? Impact assessment of ongoing awareness program? Conduct. Conduct. Any other suggestion here? So what about alternative strategies, So for example, in some places, if somebody shows up at an emergency, you don't deny treatment. You just treat everybody. But what sort of challenges can that lead to? There are. So. So, but like. But how do we solve? Because this is a very serious issue. This is a major issue. Many people are left out. When you say universal, it has to cover everybody. So now the first question is, should everybody who is a state citizen be covered? Who should be covered? It's throughout the year. Yeah. Or what about making these, going out, community outreach? They do that. So there they make these cards? To make the cards. But how do we... अच्छा
They are reluctant to make it.
they are reluctant to get the Aadhaar card, and without Aadhaar you can't get the MHIS card. Okay, so what is the solution here?
Before Aadhaar, there is no problem. It's just the effect is
Sorry.
Without Aadhaar also,
हाँ. अच्छा.
Aadhaar card will not resolve that issue. Why can't you see why that is happening and something is not
In the state.
हाँ.
No, but then नहीं, but then who is from the state? How do you decide? Let's say.
So what I think, once because our database is there.
अच्छा. So
that is one. Now we are a citizen of the state. We have to make a voter ID, which is the head of family of the voter ID. Now we register the head. We add any other beneficiaries we would require that. Any government needs to building a relationship. Answer. First. Now, the next thing what if they this Aadhaar is there's only one Aadhaar for one beneficiary? You can do the Aadhaar. Right? That is the whole purpose of that. I think we will not spend on people from other states or other countries.
So should we say that they should also strengthen the registration systems under electoral database, birth and death registration, marriage registration?
As of now, our registration our hospitalization is March even back up to 11%. So we are in and at the same time, people are registering Aadhaar, if you have the benefit of that, we are not going to do a ration. To solve the problem of many other things.
But one question is, if the 90% of MHIS is funded by the state, why do you follow this National Health Authority?
More money to the market, but also there's only one beneficiary. The patient has already registered Aadhaar and SAP. In terms of Meghalaya, as a Meghalaya, in terms of DCU, they will not accept.
Actually, the fingerprint will not accept because of the biometric system. But you know, the biometric also is a problem because I heard some people say that people who are manual workers, their fingerprints also keep changing. See, we are working on laptop, but those who are lifting bricks and...
See, there are three things. We have the biometrics, we have the face recognition, and we have the iris.
Acha. Okay. Okay. So one of the three should work. Okay. So the point here would be to strengthen the Aadhaar registration, right? So strength.
any especially rural areas where you want to have a communication. They are people from state.
Identification. Yeah.
Birth certificate,
Yeah, yeah.
so probably one of the things how to identify
So strengthen basic CRVS, the civil registration system. But you know, it's easy to say they strengthen this and that, but how do you do this?
the solution to have is the FNP is very important. Because there are a lot of people sometimes who has to identify this is of this village. Then it goes to the review. The review also will outside of the same as per the eventually they get one document where they get
Oh, okay, okay. So can the village health committees play a role here? So, yeah, councils. Can they? Village health. We can say that village health councils, right? Health councils can play a central role here. Role in strengthening registration. Registration systems and liaising with officials. Okay. Any other thing here? So they will also get more respectable treatment from the village councils, right? Councils can maintain the CRS in the localities. Great. So the other thing is abandoned cases. What do we suggest here? Abandoned cases. What is the solution? You had mentioned this problem. What do you suggest? How do we solve this? They are from. But if they have no documents, how do you know which district they are from? Announcing? Oh, asking the patient. Acha, they can. Oh. Oh. But how do you get to know that they are from Bangladesh? Asking them. No, but so they tell you, or they tell you, okay, I am from Bangladesh. Oh. Exactly, yeah. So what is the solution? So from a health perspective, what is the solution? No, but that would be about deporting them or whatever. But from a health perspective, what should we do about such cases? So should we provide treatment to abandoned cases? What is the consensus? Abandoned cases? Sorry?
I think this will not be policy.
Achha, it will require a new.
Shouldn't be the responsibility of the hospital.
Sorry?
Shouldn't be the responsibility of the hospital. I think they should have
Is this a big problem? Is this a big problem or no?
Consuming more of the resources of the hospital.
Clothing for the
The engine.
It may or may not be material, but as long as it might be material,
To the hospital. So they are brought to the mental health hospital. Okay.
and sometimes the police have already diagnosed them. And sometimes I feel it's
So it should involve social welfare. Oh, this is there. Acha, acha. So abandoned cases are brought by police and NGOs. So they are brought to your mental health hospital.
Because those abandoned again, that comes to the same point, they're abandoned.
So I mean, there is the Universal Declaration of Human Rights by the UN. So I think there have to be some sort of, because when you say universal, it's very difficult to decide whom to include. Now these are abandoned cases. You don't know whether they are from Meghalaya or not. Where are they from? Now there has to be a certain level of humanity also. You can't just say, I don't know you, get lost. So without identification, again is the issue of identification also, right? So where do you draw the line, between resources and identification and all the. Until we care for them. No? That's a good suggestion, because there is, let's say you stabilize them, you bring them to a certain level, or you take care of them for so many days, and then after that you say, sorry, we can't do more than this. That's a great suggestion actually, yeah. So if there is any other suggestion on this issue, we have two solutions. No, but abandoned cases in general, because it's not necessarily related to mental health. It can be from other departments also, right? Let's say you find a person lying outside. What do you do with that? Multi-ministerial, exactly. Now, lack of assessment of various health challenges, inequalities, and roadmap. Any solutions? Conduct studies? Checklists. For certain indicators. With certain indicators. No, but challenges can also be identified through challenge checklists. Whether this person, let's say, how do you detect diabetes? You have these issues, and then okay, if this is all, you have diabetes. That's the. This is what you mean, right? You have a checklist based on which you do the assessment. Right. Not all of infectious would be a challenge, right? It won't work. So we can say IT. Sure. And what about roadmap? Developing a roadmap? But we can say that we also involve various stakeholders. Collaborative of roadmaps, especially involving communities. Right? Now again, collaborative partnerships with NGOs, international organizations. What do we do? Should we have regular meetings with them? So need-based, we can say need-based, need-based partnerships with various stakeholders. So any other ideas about how we can develop collaborations with different stakeholders? How do we do that? Sure. Please come. If you can, others will also benefit from you. From your.
Actually, government of that has entered a partnership with development and self-technology. So to strengthen the ecosystem industry. The thing is that with this, we are trying to increase the availability and the accessibility of
blood in the state.
The thing is that before we did this, what we did was we had the current situation, situation analysis. After doing that, we highlighted the problems, and then we have to first certain strategies. Because these strategies, there are 4 strategies which we have to work with all these stakeholders, like all the state, the hospitals, and community, and we go down to the grassroots. We're trying to work with all of them. Of course, like we mentioned, the different departments also, like the social welfare, the school, education department, sport department, because we need people to come forward to create. We need people to change their behavior. So development what is really helping us. When it comes to the financing part, the government also is helping us.
Okay.
So we're trying to work together, trying to change the behavior of the people to come forward. Of course, this is time bound. This is time bound. We have to, because the first phase will be till the month of October. So this is time bound. At the same time, we will have the evaluation. It will be monitored. At the same time, the evaluation will also be there. Like you mentioned, the impact of the events program, which we will be having in the next 4 months. Starting with the month July. So we hope that this one will the boy district will include the voluntary contribution because in our state, donation is just 17%. Yeah, that's against the national average of 76. So we really need to work hard on this. And if this works out in the boy district, maybe it will serve as a model for other districts.
Districts,
So this is what we're trying to do. This is a kind of a collaborative
with the parent. Okay. So this is in the form of an MOU, right? MOU, okay. Or it would also be a contracting, right? Contracting of services?
They also bring something from their end, like for the IC materials. The IC materials that we have to be pamphlets with the comics.
Okay.
Videos. So these are the things we need to now from the month of October, we need to implement. That's not a time to take very tough also. Because we need to go down to the grassroots level.
So the question would be, how do we leverage the expertise of different groups? So because you felt that this organization has this expertise and can help us to IC part of it. Right. Exactly, yeah. Right. So what should be mentioned as a solution from your side? What do you think? Oh, this is gone.
So we feel that this will help us improving the availability. Because if the first phase works out, the first phase means to change the behavior of the people in that street. So if that one works out, then we can go to the second phase. The second phase is to improve the accessibility. That means we already have a blood bank there in Nongpor. So if the first phase works out, then the blood bank in Nongpor will act as a hub. And we'll start, setting up these blood storage centers in the different districts. So in that way, it improves the accessibility. So this is something which
yeah. So we can say pilot new initiatives. So as a solution, what should we say? So the question is, how do we an example, yeah. So there is already happening. Right. Different stakeholders.
Nothing right senses, I don't want to share that.
Exactly, yeah.
But I think it will be, I think it will be helpful.
Yeah, so this could
definitely increase because we have the WHO recommendation the blood donation in the state, 100%. So 17 to 100, so that's a
blood. So I can say there is this emerging good practice.
voluntary blood donation at the same time. The first phase works out really accessibility of blood.
Voluntary blood donation. Okay, pilot is happening, right? What is the spelling? Dermo. T. Termo. Terumo. Right? This is blood cell technologies. This isn't from South India. Okay. How about collaborating with international organizations? Spyro. Jamaica, okay.
So basically, diagnostics, we provide diagnostics, there is a warehouse, and from there, we distribute to different subsets.
Okay, okay. So we can also call this an emerging good practice, which is warehouse for medical, for drugs and diagnostics, centralized. Uh, for supply to facilities, direct supply. Up to sub-center level. Sub-center level. No, but one question here would be, how do we develop more partnerships with various stakeholders? How do we do that? Mm-hmm. Yeah, with major stakeholders. Yeah. How do we develop that? Like I'll give you awareness. Huh? So awareness about having collaborations. Awareness and slash possibilities for collaborations. Because you see, for universal health coverage is a complex thing, and you need to bring in different stakeholders, different sorts of expertise. Now the question is, how do we do that exactly? And this capacity to develop and lead collaborations has to be primarily with policymakers. So policymakers and health leaders should have the capacity to develop and lead collaborations. So how do we do that? Oh, okay. Right now, approvals for collaboration needed from Principal Secretary. Principal Secretary is for the departmental Principal Secretary. Okay. So that is, so simplify procedures. But then sorry. Mhm. So okay, light is gone. So develop documentation for SOP. Develop SOPs for collaborations. And who should be authorized to enter into collaborations? Hmm. Hmm. Ah. Okay. Yeah. But this is important when, so when you say SOPs, we can also say financing, yeah, models. No problem, huh? Top level policymakers need to authorize financing, because financing. Go to
they can, buy equipment. So in that way, the win-win. Online platform where we submit what we want to use to
How about having a centralized database where the needs are highlighted? I need this, for example. And then there is a committee which says, okay, for this, we need to collaborate with this. How about that? Difficult. Huh? Right. Yeah, exactly. Exactly. Right. But that is only one person. Can there be a centralized system where different organizations raise their problems and this group, let's say, decides who do you collaborate with? Because the principal secretary might have all other concerns also, right? That is one person who is burdened with many issues at the same time, and one person may not have the time to take all the decisions. Many consultants. Okay. So the consultant to help. Right. So what should be the solution here? How should we frame it? And Okay, so top level policymakers. Should there also be an outreach program to different stakeholders? So let's say, because if you, let's say, share what you are doing in the state with different organizations, they can also say, okay, we can help you here in this regard. Let's say WHO has some expertise or some funding, whatever. And if you keep sharing, so then they also know you are doing this and this. Planning department. Okay. So outreach to different stakeholders. For dissemination purposes, you can say. And they can also suggest, propose collaborations. Great. So last point here is communities are resistant to behavioral change programs of Village Health, Sanitation and Nutrition Committee. So behavioral communities resistance to behavioral change programs. How do we solve this? Communities are resistant to behavioral change programs. Yeah. Yeah, exactly. So I'm actually thinking that we can share these solutions with others also, and they can also contemplate and they can add points. It also gets consultative. After awareness programs. Great. What else should be there? What about decentralization? Letting communities make a lot of decisions. Just community. Acha, Jan Arogya Samiti. Yeah. This is part of which program? CPHC. ये अंडर आयुष्मान भारत. हाँ. This is being done. Men. Men. Oh, by jazz. So these samitis are formed in every village, every sub-center. Every sub-center. So you think the composition of this jazz is the local people and so how are these people decided? Who should be part of jazz? How do you decide? Acha, acha. So how can they help in dealing with resistant communities? Announcements. So so you think more and more involvement is going to help in tackling this? I think the idea of community health needs assessment is also very important, because if they feel that this one is the top down approach, you have some program, something, you take it to them and then try to see whether they have the awareness and why they are accepting or not. But if it is a bottom up approach, if the things come from their side, this is our need, this is what needs to be done, then there is more acceptance also. So is that something that you think would help? Huh? Bottoms up approach to planning, especially approach to health needs assessment, planning, etc. Because I think, like somebody was saying that, you were mentioning that targets should be given to them. Now the problem is, you decide at the top and then you give targets, but then there is no acceptance at the ground level. So you can't even meet the targets. How do you meet those targets then? They are using the local resources. Exactly. Yeah. So resource mobilization also, because this idea of pooling under UHC, and I think also for health insurance, resource pooling is a very important strategy. So because resources have to come from different sides, and communities can also do resource pooling. So can we say that more involvement of communities in planning and needs assessment and all of that, would that be a solution? They are already there, right.
So one patient is fine. So regarding the GST of each and every medicine.
GST? The tax. Okay.
Can't we just give a slight change to the tax? Like for those with chronic conditions, if it's the same as almost with the others, the general point of view. So can there be some changes?
You mean remove the GST?
Yes.
From medicines?
But according to what the planning, if we can reduce or do something like that.
Reduce the GST on medicines.
Especially those with chronic conditions.
with chronic. So that would be under financing.
Yes.
Financing. So we can mention under financing. But then you are. So you mean then out of pocket spending would be reduced?
So some subsidized rate will be
So
talking about
subsidized medicines, right. So we can mention that subsidization of medicines.
So that's also being done.
Oh, this Jan Aushadhi, generic medicines are there.
Oh, yes.
So, okay, we are done with this part of it, governance part. It's taking a lot more time than I anticipated. So, governance part we have done. Now, what do you suggest? How do we go forward? So, it's 1:30 now. Should we go out for lunch and then come back for financing? What is the status of lunch? First, we need to know if the lunch is there, like yesterday. So, inadequate. So now we are moving to financing. So, inadequate financing. What do we do about it? What can be done to do adequate financing? So one was that we discussed yesterday, we can strengthen promotive and preventive programs. That is very cost effective. Is that one solution that you think should be done? Strengthen disease prevention and health promotion to reduce the burden, financial burden. Because one challenge here is inadequate financing. How do we tackle that?
So one was not insurance, and two others.
Yeah, but insurance also you need money to. How do we tackle the problem of inadequate financing? See, so I think, is there any economist here? There's no economist, right? Or public health people. So from a public health perspective, the solution would be that, we improve public health measures. So what the other is, So strengthen public health and quality of care. So quality of care would require more strong monitoring systems. So strengthen public health, quality of care, M&E systems. What else? What all can be done from a public health perspective?
Early interventions.
Early intervention. Yeah, that would be. Yeah. So that would be under disease prevention, health promotion, all of that, public health, quality of care, M&E systems. Can funds come from within communities also? Can, like somebody was saying, pooling of resources by. Sorry?
How are you utilizing these funds building walls and so these things are and we do have the untied funds also.
Untied funds.
So the untied funds when we buy medicines, we buy all consumables. That's already given.
So one aspect of health promotion is that you empower people and communities to take care of their health. So human agency, strengthening of human agency is very important. So one is that, one approach to UHC could be that my hand is like this, you keep giving me. The other is you empower me to take care of my health. So how do we empower, communities? So one is also, let's say, if people are rich, there would be no problem of out-of-pocket expenditure because they have money, they can pay. Like rich people go to big hospitals, they don't find it difficult. So also, to be economically prosperous, you also need good health. So if you're sick, you can't work. There will be absences, leaves, because you are sick. You will take a lot of leaves also. Your productivity will go down. So how do we, how do we strengthen human agency and how do we strengthen the communities to take care of their health? Because in health promotion, the idea is to strengthen, empower people and communities to take care of their health. That's a very important component. It's not just about top down, it's also, how do you strengthen them? Food supply.
Good clean water, then these are the
So public health measures basically, yeah.
potable water is not there or in India.
It is there.
It's there, sir. Potable water.
Mm-hmm.
Where do we get potable water?
Potable water is there or should be there?
No, it should be there, sir.
It should be there. Achha. And what about food supply you were saying?
So I think, I don't know if it's true or not, but I've heard that the further you are from the capital, the worse the quality of the food. So rice grains, lentils.
And some for the vegetarians is
So strengthen food availability and safety. Okay. What about then inadequate strategic planning for allocation and purchasing vis-a-vis the country? That's also covered there, I think, because strategic. I think there, in terms of strategic planning, so like you have, in economics, you always have limited resources and you have unlimited needs. So how do you, do priority setting to use the limited resources for the best sort of, where do I put the money? Let's say you have 100 rupees and there are too many things to cater. So where do you use that 100 rupees? Because you will never have unlimited money. Money will always be limited. So how do you do priority setting? How do you set priorities? That's a big question because priority setting has to come in at some level. Because you can keep saying, I don't have the money, but you will always have little money. Even the super rich will say, I don't have money. Because there will be certain things you would want to do for which you will not have the money. So how do you prioritize as a state? So where do I put my money? I have this money, where do I put it? That's the question. Let's say the state government is saying, I have this much money. You tell me as public health experts, where should I put this money to get the best health outcomes?
I think we talk about that. So it's always a three-pronged approach there. First, faster human resource and now which one comes ahead of the other? I don't know.
No, but then how do we also ensure that these things lead to proper health outcomes also?
So that's again where we lack data.
Data is also missing because you can hire more people, construct more buildings, get more medical supplies, but how is all this leading to better health outcomes? How do you do that?
I think so that what you're saying is we all have to go in for quality.
Quality is to be
That's
there.
the only thing. Then the outcome will come.
Quality has to be prioritized.
We have to prioritize on quality.
Quality of care has to be prioritized.
Quality of everything, so quality of our infrastructure, quality of our equipment, quality of just.
Does everybody agree with this proposition? That quality has to be a central focus? Anything else? Do you think today the light load shedding is? So do you think communities need to be involved to do priority setting?
Yes.
Where to put the money?
At least we can listen to them.
Listen to them.
She has a very good point. Because she said at the end of the day, communities have to take ownership
Of the health.
of their so the health system.
So this would. So when you say they should take ownership of their health, what exactly do you mean? Like they should be.
We give them awareness. Now they will take ownership of, like, whatever information they give them. If they feel it's important, we have the ownership they give. Right? So they understand the importance of them taking care of their health. And so this is a big investment. And that's then given back to you. That's
Talk about community. You tell them to be healthy, you can be productive.
it's an investment. It's investment.
Right. But also, health is a particular field where you always require expertise. Like, you can't tell the people, okay, just, do something to be healthy. You need doctors, experts to bring in that specialized knowledge. This health always.
Awareness. So if you're going to give them
We give
awareness,
awareness and we will impact assessment of this awareness. To see that if they really comply with this, whatever information they will provide.
So let me discuss a very radical idea. Let's say we turn the whole health planning upside down. Let's say we give 1 billion rupees to all the village health committees. You say the government is not doing any planning. We'll transfer this 1 billion rupees to your account, village health committee, every year. Now you have the ownership of your health. You tell us what do you need, how will you use this? You do all the planning and you let us know whatever resources you need. Do you think that's something that can work out? Let them do the planning. Let's say they say we need doctors to help us, diagnose this, or we need experts on this particular issue. Do you think? Because right now what is happening is that every planning, everything is happening at the top. See, where do the governments get their money from? Governments take taxes, direct and indirect taxes. The money is coming from the people. Money is not going on trees. The government gets the money from the people itself. And then they do the planning and then they allocate, funds for different programs or whatever is being done. But what about giving people the money that is coming from their side itself and telling them to do all the planning, take ownership? Do you think that's going to work? Because right now the approach is that we know and they don't know. So, like people sitting in the ministry, they have this thing that, okay, I know everything, I will develop the programs and I will tell you, you do this and that. But what about we turn this model upside down?
So yesterday somebody was mentioning about hand holding. So I think that process can be done in that level. Because if there is no monitoring, there is no evaluating, again misappropriation of funds will be present. That level as well.
Right.
It has to be done.
Yeah. Because misappropriation of funds. But right now also a misappropriation of funds. Healthcare corruption. No? Because I think we feel, okay, we know everything, we'll do it the best way, and if you give money to them, they will, eat up and run away. But corruption is, everywhere, in healthcare also. So,
talking about the economic point of view, if we come to the topic of accumulative deficit also, we have to take a look regarding that.
Accumulative deficit. So, what is that? Ha.
The fund, where is it accumulated and why is it every year it's going on a waste? That's one thing which we need to see.
Where is it going to waste? The money. Can you elaborate a little bit more?
So that is what it is. Every year we have to see the immediate picture. So the fund is going, but is it being resourceful? Is it being helpful towards the various centers?
So technical capacity building for utilization of funds is also something which is there. Like, a lot of centers get the money, but they don't know how to use the funds. So that sort of technical capacity building also for utilization has to be there. Regarding the strategic planning for allocation and purchasing, so one is that we have written quality of everything has to be prioritized. Communities should be involved in priority setting, and at the end they should take ownership of their health. So anything else do you think we should write here? So centralized purchasing is already there, right here? Centralized procurement for medicines and drugs. What about, so everything, all the logistics, all the things are centrally procured, or only the drugs and only drugs? Everything is centrally.
Surgical items, diagnostics, reagents.
Sorry?
Reagents, that's reagents.
Everything is. And has that led to efficiencies? Acha. Now, one question is, how do we tackle health inequalities here? Through allocation, and how do we tackle health inequalities?
So again, resources, make sure that we have.
Excuse me, sir. Don't mind actually. I've got really well.
Oh, please. Please take care. Okay, no problem. Thanks. So, so how do we identify more vulnerable communities and individuals? That would be a challenge, because there are health inequalities. Some people are more vulnerable than others. So how can we, mapping of. So where do we get the data from for this mapping? Collaborative mapping. Lunch is there? Okay, so lunch has arrived, but we just have 2 points. We can quickly finish 2 points and then we can go for lunch. So one point is that you had mentioned financial awareness of health staff. So how do we do that, financial awareness? How can we make the health staff financially aware? And is there a need for it also? What will happen?
Because all our needs are not conveyed to whoever makes the budget. Therefore, whoever makes the budget is making some budget from somewhere, and nowhere he pulls the data from somewhere in between, and then we are supposed to do something with that. That's not correct.
So participatory.
At least let us
collaborative and participatory involvement of budgeting. So especially from a mental health perspective, so what do you think? Because like the burden of mental health disease is also not known. So in that particular case, how would you decide that what sort of resources are required?
One person is sick in family, it becomes a burden to the whole family.
Yeah.
If they cannot leave their places and their work, so they have to take care of that.
Yeah, no, but I'm saying if we don't know the burden of mental health diseases in the state, how do we decide on the resources that we need to solve that burden, tackle that burden of mental health in the state? So, do you think because I mean, if you say doctors should do it, but the thing is, will the doctors be aware about the burden at the state level? So that would be a broader exercise at the population level. So should we say that there should be a rapid survey or discussions, workshops, consultative workshops to come to certain understanding?
There has to be some kind of studies also.
Studies.
Mental illness will be various kinds. Most of them will be chronic illnesses. Requires long-term treatment.
Right.
So that kind of studies will be there.
Right.
Illnesses.
So studies,
And
surveys,
workshops
workshops are
are being conducted.
being conducted. So is there a workshop before the budget is made, like with different stakeholders? There is no discussion with the. Okay, great. So collaborative and participatory involvement should be there for budgeting. There should be consultative workshops, and there should be studies and surveys to understand the needs.
So as per now, like even disease-wise data, like we have the institutionalized one, whichever patients come into our institution.
Right,
so
right.
we do have the data.
Right,
like,
right.
Which diseases are like more like
More prevalent, for which they're coming.
some district-wise, some.
But is that data analyzed and usable?
So we are sending the data, but I'm not sure.
Ah. Okay. So we can say enhanced use of data for planning purposes.
I think so exactly that's what we think in the PIP for management. We have indicators, based on these indicators, funding is being they fund based on the burden of the certain program. For now, more focuses on CPHC. Most of the funds now go to the CPHC because we require rigorous training, capacity building. So while we carry the PIP, the burden of every program is being addressed, and also we give the amount of why we need more money for this. The main problem with mental health is they hardly get any funds.
You don't get funds.
PIPs are made, sir, not in consultations with doctors.
Sorry?
PIPs are made not in consultation with doctors.
Okay.
And neither is that information shared ever. So they have no
PIP,
idea at
they are
all.
only involving the NHM and the nodal officer. Like we have a CPHC nodal officer at the district. So we prepare a district PIP. And then the state will compile all the but yes, there's no involvement of all the medical.
So involvement of doctors, or also what about others?
Doctors, even our healthcare professionals and nurses and it's also very important to involve in pre-budgeting process.
So in developing PIPs, you are saying. So PIPs are only developed for NHM, right? NHM PIPs. Great. So last point before we break for lunch, cost effectiveness analysis and interventions. So we should do cost effectiveness analysis. So so NHM also has something. NHM, the approved budget is called the ROP. What is the full record of proceedings? So if you look at the NHM ROPs, the budget for surveys, studies, review and analysis is 0.01 or 2%, not even half a percent. Even in a state like Kerala, so this review, studies, analysis, this is very low. So how can that be increased? Because you're saying cost effectiveness analysis of interventions needs to be done, or monitoring and evaluation systems need to be strengthened, but you are spending less than 0.5% of NHM budget on all these activities.
So, this is in a pipeline, conceptualizing this positive public health approach.
Conceptualizing?
Conceptualizing of a positive public health approach.
Okay, what is that?
All these, it's still like in a conceptualization. The Bible has been supporting the state with this, analyzing the finance of the state, like where the money goes, how the money goes. Where do we find, there are loopholes in financing. So that is still in the pipeline now. We are still conceptualizing how to go about it with this. So to bring about increasing all the money.
So who's doing this conceptualizing? Who is doing the
the state, and then the Bible is also supporting.
JPIGO.
Yeah, we as international organization
Acha, acha.
supporting the state.
So
Analyzing of
JPIGO is, so state with JPIGO is doing a positive public health approach. So analyzing the financing patterns at the state level. Great. Because that somehow needs to go up, because you can keep spending resources, money, and so that's a very resources approach, but what are you achieving with that? So do you think there should also be awareness about, in the health staff that, we are doing these programs, but you also need to be conscious about the health outcomes? What are we achieving out of all this,
for disaster management by the state. So how to overcome the
No, but constant, building in a culture of monitoring and evaluation. How?
You can measure the results to understand the accountability.
Yeah. But what about having that approach in general, that monitoring and evaluation approach in general? That whatever we do, there have to be impacts that we need to be conscious about, whatever we are doing, because otherwise you keep putting the resources, and so how do we, can we say that we develop a culture of accountability and monitoring and evaluation among the health staff? Any other points, or we can go for lunch? Any other issues? See, the idea is just to, so let me just clarify that the idea here is just to, see what comes to our mind in the first place. Of course, to develop solutions, you need more research and, planning and all of that. But the idea is to do all these things collaboratively. How can we work collaboratively? So my observation is, one observation is that how do we ensure that everybody participates in collaborative planning, and so how do we ensure that because this is like a small scale experiment, but if you go out and work with communities and other stakeholders, how do you ensure that everybody is adequately involved? That is my last question. How do we ensure that adequate participation of various stakeholders in discussions and all of that?
Unless they see something for themselves, nobody's will do it.
Right. So how do we convey that gain to them?
So first, out of pocket expenses, you can dangle and hope for the quality of care. Perhaps they can do more.
The public.
Say you don't have to go too far. We do these services. is that somebody has to explain basic economics to them.
Like we give a certain amount for them, monthly, whatever their work.
To the health staff. Oh, you mean monthly payments to them? Okay. So should we close for lunch now and then? I think going forward, what I would suggest is in the next session, what we can do is we can instead of going one by one problem, we can discuss general solutions. I think because we also want to wrap up the sessions quickly, and the last thing that I would want to do is to see what should be the way forward. Like you have spent two days and we have all sat together, so this should not go to waste. What should we all do as a group, because we have already invested 2 days. So how do we ensure that we take it forward and it leads to something? And so what are those things that can be done to sustain, what we have achieved in the past 2 days and, for the future. So that is something also I would like to discuss after lunch. So let's have a quick round after lunch about, general solutions. Let's not go point by point. And then let's spend some time about sustaining such, because from my perspective the idea was that we adopt a collaborative approach to identifying the status and challenges and developing solutions, and then seeing that how this collaborative sort of thing can be promoted and also scaled up, because right now this is a small group, we are 15, 20, 30 people. But how can this be scaled up? So what can be done about scaling up because as I said earlier also, that UHC is a complex thing. It's not going to be solved by one group of people. We will require collaborations across multiple stakeholders, multiple people. So how do we do that collaboration and ensure that collaboration is useful? I mean, not just for the sake of it, but how to make that useful. So those are some things that we can discuss post lunch and then close the meeting. Yeah. Great. Thank you so much for your time and patience. Yeah.